Okay, let's unpack this fascinating review you've shared with us, really digging into AI in cardio-oncology. It's pretty amazing how far cancer treatments have come,
Mhm.
the last couple of decades. Huge strides.
Absolutely incredible progress.
Yeah.
Patients are living longer, better lives. But yeah, these powerful treatments, they can sometimes hit the heart pretty hard. That's cardiotoxicity.
Right, cardiotoxicity. And that tension, fighting cancer while protecting the heart, that's really fueled the growth of this whole specialized field, cardio-oncology.
Exactly. It pulls together expertise from, well, oncology, obviously, cardiology, internal medicine.
Yeah.
It's a team effort.
And there are guidelines out there, which is great, but managing this stuff is still really complex. Like, just the burden of routine screening all those echocardiograms for potentially low-risk people, it's tough.
It really is. Tough on patients, tough on the system, and then trying to optimize strategies for all the different kinds of cancer therapies we have now.
Yeah.
Well, it's tricky.
Which is where this review suggests AI might step in. Artificial intelligence. It's got this like unique ability to chew through massive data sets and spot these really subtle patterns, things we might just miss otherwise.
Yeah, that's the core idea. Integrating all these different kinds of data, clinical notes, labs, images, and finding connections. AI could potentially help us get much, much better at predicting risk, diagnosing issues earlier, maybe even tailoring treatments in cardio-oncology.
So our mission today is basically to explore what the review says AI is doing now and what it could do down the line. We'll look at how it uses different data, its potential, the roadblocks, all based on this specific paper. We're mainly talking machine learning, ML, and the more complex stuff, deep learning, DL.
Okay, makes sense. So where should we start? Maybe with electronic health records,
Hmm.
EHRs.
Yeah, perfect starting point. EHRs are just gold mines, aren't they? Demographics, patient history, labs, imaging reports, meds, even genomic data sometimes. Just vast amounts of info collected over time.
It's just huge. And AI is, well, it's kind of built for that kind of deep longitudinal data. You can train it to build models that predict the risk of CTRCD, cancer treatment-related cardiac dysfunction.
CTRCD, that's the general term for heart problems cropping up from treatment like heart failure or rhythm issues.
Exactly. And the review mentioned some really neat examples of AI using EHRs for this. One study used something called a patient network analysis, looked at a big database.
How did that work, like mapping connections between similar patients?
Sort of, yeah. Identifying groups based on shared characteristics. And they found that certain blood markers, NT-proBNP and troponin T, were pretty significant predictors of mortality in some of the high-risk groups they found.
Okay, those are markers for heart stress or damage, right? So AI helped figure out how important they were when combined with other factors across lots of patients.
Precisely. It sees the bigger picture. Then there was another study in the review. They built several different prediction models for CTRCD. They used different ML methods, different data mixes from the EHR labs, echo results, or both combined.
And what did they find? Did combining data work better?
It did, yeah. The models using combined data sources generally had higher accuracy for predicting different heart outcomes. But interestingly, even a, let's say, simpler method like logistic regression did surprisingly well for many predictions in that study.
Huh. So it's not always about the most complex AI. Sometimes clever use of existing methods on rich data works.
That's a key point. It underlines the importance of the data itself. But then again, a third study they mentioned used more advanced stuff, random forest, artificial neural networks, to predict CTR-CD risk across different cancers and treatments, including immunotherapies. And the neural network model did show really high accuracy there.
Okay, so the takeaway with EHR seems to be AI helps us wade through all this complex clinical data to find patients at higher risk, maybe better than just looking at a few standard factors.
Definitely. But, like the review says, there's no single magic bullet algorithm, right? Different approaches work better for different questions.
Makes sense. Okay, so moving on from patient records, what about a tool we use all the time? The ECG, electrocardiogram.
Ah, yes, the ECG, foundational tool. Cheap, easy, widely available for assessment and monitoring in cardio-oncology. Standard stuff.
But standard interpretation only tells you so much. This is where AI ECG comes in, you were saying, finding subtle things.
Exactly. Things the human eye might just skim over. AI ECG is already showing some promise outside cancer, like spotting signs of asymptomatic left ventricular dysfunction, a weak heart pump even when the ECG looks normal to us.
Wow, or detecting hints of atrial fibrillation risk even during normal rhythm, things like that.
Yeah, or helping assess things like long QT syndrome. But the review focuses on the cancer patient applications, which is really exciting.
Okay, so what did it say specifically for cancer patients?
Well, they've developed AI ECG models specifically to predict that left ventricular dysfunction, LVD,
Hmm.
in high-risk groups. Think childhood cancer survivors or breast cancer patients getting anthracyclines. And these AI models were consistently more accurate than just using the standard clinical risk factors.
More accurate than looking at age, dose, that kind of thing.
That's what the studies suggested. And one study used transfer learning, took an AI model trained on general patients, and fine-tuned it for cancer patients. It could predict LVD risk just from the baseline ECG before treatment even started.
Independently of other risk factors.
Independently, yeah. Even independent of things like drug dose, it's significantly boosted prediction accuracy compared to just clinical factors.
That's pretty powerful. What else?
Maybe even more fascinating, one study used AI ECG longitudinally. They looked at ECGs over time from the same patient.
Yeah.
And the AI score changed dynamically. It actually anticipated CTR-CD happening before it was obvious clinically or picked up by other tests.
Whoa. So it's potentially seeing subtle electrical changes that reflect actual structural changes in the heart muscle almost in real time.
That's the implication, yeah. Really exciting stuff. And it also looks promising for predicting arrhythmias like atrial fibrillation in specific groups, say leukemia patients on certain targeted drugs.
So just thinking about this, for you, the listener, it means your standard ECG, that quick test, it could potentially hold way more information about your specific heart risk during cancer treatment.
It could become a much more powerful predictive tool, maybe flagging problems before they get serious.
Okay, let's shift gears again. Imaging. Super important in cardio-oncology, right?
Yeah.
Echo, CT scans.
Absolute critical. Baseline assessment, monitoring during treatment. Echocardiography, TTE, is the workhorse for checking heart function.
Looking at LVEF, the ejection fraction, and now GLS, global longitudinal strain, that more sensitive measure of muscle squeezing, those are key for defining CTR-CD.
Right. And AI is stepping in to refine TTE analysis. It can automate measurements like outlining the heart chambers really precisely or analyze complex strain patterns we might miss. Helps potentially spot subtle problems earlier.
The review mentioned a study using machine learning on echo images from breast cancer patients to predict LVEF drops.
Yes, exactly. And it found that specific strain patterns, particularly in certain wall segments of the left ventricle, like the midseptal and anteroseptal areas, were strong predictors of developing cardiotoxicity.
That level of detail is impressive, but you also mentioned automatization.
Ah, yes, that's a huge area. AI software that automatically calculates LVEF and GLS. Think about it. Less variability between different people doing the scan, less need for super specialized sonographers for basic measurements.
Makes echo potentially more standardized, faster.
Could be. Tools like AutoLV, EchoGo Core.
Yeah.
There are already examples of this happening.
And then there's the handheld ultrasound idea with AI assistance.
Yeah, this is really interesting for access. Studies showed oncology staff, not cardiologists or expert sonographers, using these AI-assisted handheld devices.
And they could accurately spot impaired LVEF.
Their accuracy was comparable to trained cardiologists using standard machines, according to those studies. It's pretty remarkable.
Wow. So that could mean point-of-care cardiac checks right in the oncology clinic, streamlining things?
Potentially, yes. Faster checks, quicker identification of potential issues without needing a separate cardiology referral every single time. It could really change workflows.
Okay, and beyond echo. CT scans. Cancer patients get a lot of those anyway, right? For staging, planning, radiation.
They do. And the review highlights how AI can pull extra value from those scans that are already being done
How so?
by automatically analyzing them for cardiovascular risk factors, like coronary artery calcification, calcium buildup in the heart arteries.
So AI can just measure that automatically from, say, a chest CT done for lung cancer screening.
Exactly. Studies show AI is reliable for doing that automatically, and that the CAS score it finds is strongly linked to cardiovascular risk, even in patients scanned for other reasons like breast cancer planning or lung screening.
That's clever. Using existing scans to get bonus heart risk information without extra tests or radiation.
It's about maximizing the value of the data we already collect. So for imaging, the big picture is AI making analysis potentially faster, more detailed, more accessible, and squeezing more information out of existing procedures.
Right. Okay, let's pivot to biomarkers. Blood tests. We mentioned troponins, natriuretic peptides earlier. We use them, but the guidelines say their predictive power for CTR-CD alone is maybe limited right now.
That's the current view, yes. Their predictive value isn't considered super strong on their own for this specific purpose, according to guidelines. But AI might change that.
How? By making the markers more predictive.
That's the potential. The review notes that while there aren't many studies in cardio-oncology specifically using AI with these markers yet, the research in general cardiology is very suggestive.
Like,
Well, examples where AI models using troponin levels help diagnose heart attacks more accurately, or models using NT-proBNP diagnosed acute heart failure better than just looking at the biomarker level itself. Significantly better performance.
okay, so if AI can boost the predictive power of these markers in general cardiology.
It strongly suggests it could do the same for cancer patients at risk of cardiotoxicity. We might be able to unlock much more predictive value from these common tests.
And you mentioned wearables earlier in connection with this.
Right, the review touches on a very early study, kind of a proof of concept, using a wrist wearable sensor.
Measuring troponin through the skin. Seriously.
Transdermal troponin, yeah,
Yeah.
with the data analyzed by a deep learning model. It's preliminary, but shows it might be feasible.
Wow. So that opens the door to continuous remote monitoring. Imagine tracking a key heart marker constantly for high-risk patients.
Exactly. Think about conditions like immune-related myocarditis, which can come on fast. Continuous monitoring could allow for much, much earlier detection when time is critical.
So the potential here is AI making blood tests and maybe future wearables much smarter tools for early detection and ongoing monitoring.
That's the hope, yeah. Turning static measurements into more dynamic insights.
Okay, stepping back even further. Let's talk digital health more broadly. Telemedicine, wearables, online resources. How does AI fit into that whole picture for cardio-oncology?
AI can kind of supercharge those digital tools.
Yeah.
You could have AI-powered chatbots gathering detailed patient symptom information efficiently,
Word.
or AI analyzing the constant stream of data from wearables we just talked about.
And what benefits does the review see for cardio-oncology patients specifically?
Well, potentially improving access to specialized care, especially if you live far from a major center, enhancing monitoring with that continuous data, maybe facilitating better communication between you and your doctors.
And even helping with patient education or sticking to complex treatment plans.
Possibly, yes. The idea is that digital health combined with AI could offer this continuous, personalized layer of support and monitoring that extends beyond just clinic visits.
This all sounds incredibly promising. Like AI could genuinely reshape how we manage cardiotoxicity. But the review doesn't just paint a rosy picture, right? There are challenges.
Oh, absolutely. Big challenges. Integrating AI isn't simple. For starters, there's just less research specifically in cancer patients compared to general cardiology. We need more evidence in this specific group.
And data is a huge one, I imagine.
Massive. You need large, high-quality data sets. But crucially, they need to be integrated, bringing together the cancer data, the heart data, EHRs, imaging, biomarkers, maybe genomics all in one place. That's tough.
And once you build a model, you have to prove it works, right?
Definitely. Rigorous testing is key. External validation on completely new patient data sets, prospective testing where you apply it going forward, and you need to test it in diverse patient groups to make sure it works for everyone.
That leads into ethical concerns too, doesn't it? Like bias.
A major concern. If the data used to train AI isn't diverse, the AI could end up performing worse for certain groups, potentially making health disparities even worse. And then there's data privacy. Handling all this sensitive information responsibly, complying with HIPAA, GDPR.
Plus the practical side. Getting AI into clinics, healthcare systems need the right tech infrastructure.
Right. And clinicians need training. They need to understand the tools, trust them, know their limitations. The AI models themselves, especially deep learning, can be black boxes. Hard to understand exactly why they make a certain prediction.
That must be tough for doctors and for regulators trying to approve these things.
It is. Transparency is a big issue. And the tools need to be user-friendly, fit into the workflow. It's a complex implementation puzzle.
So overcoming all this needs, well, everyone working together. Clinicians, tech people, policymakers.
Absolutely. It has to be a collaborative effort, addressing these data challenges, the ethical questions, the regulatory hurdles, the practical implementation. It's essential if AI is going to move from, promising research to being a standard part of care.
Okay, so wrapping up our deep dive based on this review. The potential for AI in cardio-oncology is just immense across EHRs, ECGs, imaging, biomarkers, wearables. It really could change the game.
The potential is definitely there. It could lead to earlier detection, better risk prediction, more personalized management of cardiotoxicity for cancer patients.
But, and it's a big but, that transformation isn't guaranteed. It really hinges on tackling those significant challenges, the data, the ethics, the regulations, actually getting it working smoothly in clinics.
Exactly. The promise is clear. But the path to widespread, effective, and equitable implementation requires careful navigation.
So here's something for you, our listener, to think about. We've heard about AI's power to find these hidden risks in incredibly complex health data. As this technology becomes more embedded in critical areas like cancer care, where the stakes are so high, how do we make sure it's used well? What steps do we as patients, doctors, developers, society need to take to ensure AI in cardio-oncology is not just technically brilliant, but also transparent, fair, trustworthy, and truly focused on improving life for every single person facing cancer? How do we bridge that gap between the amazing potential shown in research like this and getting it right in the real world?